It's only the language, also everything. I love the culture, the food, and everything else. I love it. The best restaurants are the Persian restaurants.
Yes, of course. We
Yes,
also
I love it.
we also love our cuisine.
Yes.
So I have to change plans then, and I have to change the paragraph. After introducing you, I would say a paragraph in Persian, and then we'll continue in our program in English again.
Okay.
1 more minute left.
I was in France last week and I went to a Persian restaurant in Paris. So good. So good. I love it.
So good, I know. Yeah, every kind of dish that you choose has something to say.
Yeah.
So I really recommend Persian cuisine if you find somewhere in USA. So you will have a very great time, I'm sure. So it's 3 o'clock now. It's about the time that we should start the program. First of all, I have to introduce myself. This is Shabnam Milani, Assistant Professor of Pediatric Dentistry in Tehran University of Medical Sciences. Dear Dr. Yepes, first of all, I would like to say and extend my sincere welcomes on behalf of my team at Tehran University of Medical Sciences to you. It's a great honor for all of us to virtually have you here. And in parentheses, at the beginning of our program, I would like to thank our Praise to Raise team in Tehran University of Medical Sciences, and also Dr. Roshanak Montazari, who kindly facilitated this connection between Iran and the USA. And before starting the presentation, I would like to give a brief introduction of Dr. Yepes. Dr. Yepes is a professor of pediatric dentistry at Indiana University School of Dentistry, but he is not only a pediatric dentist, but also a physician, and completed the fellowship of radiology and the residency of oral medicine. Moreover, we have moreover here, he completed a doctoral degree in public health. He is an active member of the American Academy of Pediatric Dentistry, Oral Medicine, and Maxillofacial Radiology. As I promised to Dr. Yepes, I want to say his introduction in Persian also, so I'm going to change language for about a minute or so. خب من مجددا سلام میکنم خدمت همه حاضرین، دوستان، همکارانمون. جلسه وبیناری رو خواهیم داشت با جناب دکتر یپس، پروفسور یپس، که معرفیشون بکنیم. قبل از اینکه برنامه‌مون رو شروع بکنیم، دکتر یپس پروفسور هستن از دانشگاه ایندیانا، رشته دندانپزشکی کودکان، ولی در واقع علاوه بر اینکه دندانپزشک کودکان هستن، رشته پزشکی رو هم خوندن و فلوشیپ رادیولوژی و رزیدنسی در شاخه اورال مدیسین رو هم دارن. علاوه بر این درجه دکترا در پابلیک هلث رو هم اخذ کردن. عضو فعال آکادمی پدیاتریک دنتیستری آمریکا هستن و علاوه بر این در آکادمی اورال مدیسین و رادیولوژی دهان در آمریکا فعالیت میکنن. Now getting back to English, now we are honored to have his valuable presentation entitled New Frontiers in Dental Materials to Use in Pediatric Patient. Dear participants, dear colleagues, just in case if you have any questions, kindly please write in the chat box so that after finishing the program, I can stage all your questions. Dr. Yepes, now the platform is yours and we're all ears.
Well, I really want to thank you, and this is a dream that finally is true. We start the process of the approval to give this lecture almost a year ago. It took about 14 months, and I never stopped. They asked me, you know, the university asked me so many things, so many paperwork, and I never stopped to do it for one reason. For me, it's a true dream to speak to the Tehran University of Medical Science. And this is a true dream to be connected with Iran, connected with my colleagues there, a country that is in my bucket list because I really want to go. I have too many things in my life. In the last 20 years, I interact in different ways with faculty and colleagues from Iran. I remember probably the first one, Asa Mosafari. He was one of my faculty when I did radiology, and Dr. Mostafari passed away a few years ago, but Dr. Mostafari was the kindest, and the knowledge that he had was absolutely amazing. I have a lot of, during my days as a resident at the University of Pennsylvania in Philadelphia, I have a lot of interactions with Persians. I love the food. I love the culture. And I have such a great impression. And that's the reason that in some way, obviously, I like Zoom because Zoom, allowed me to be here giving the lecture. But I hope someday to have the opportunity to be there. I really hope someday to have the opportunity to speak there. The reputation of Tehran University of Medical Science is one of the best health science centers in the world. So this is one of the places that will be an absolutely honor to be there, giving a lecture and having the opportunity to interact with my colleagues. So thank you so much. Thank you so much for your time. I am the one who need to say thank you to open the doors of your computer for me. I am the one who need to say thank you that you are taking away time from your busy day. For me here in Indiana, which we are New York time, it's early in the morning. So I usually, at this time of the day, I am just at home preparing myself to come here. But I'm doing this with all my heart. I love it. If I will need to be here by 3 a.m., believe me, I will be here by 3 a.m.
Thank you so much.
I really, I want to just say a few words. Kind of an introduction of this lecture. This lecture, the title is New Frontiers. I honestly, and you are going to see that in a few minutes, I probably need to replace new frontiers for frontiers, because what happened is some of the dental materials that I'm going to discuss today, they have been around us for a long time. Maybe we are just realized that they are so good that we need to use it. But the term new frontiers is not exactly precise, because some of the dental materials, for example, silver diamine. And as a pediatric dentist, I'm going to say a few words about silver diamine, which honestly, for us here in the United States, silver diamine was approved, I believe, in 2015, 2016. So it's kind of a new frontier. But in other countries in the world, silver diamine has been used for a long time. So this is going to be a very interesting lecture. Please forgive me if some of the concepts and some of the topics that I'm going to discuss, you are an expert. I'm sure some of you are an expert. And because I didn't do a questionnaire before to try to understand what is the level of understanding that you have of some of the material that I have. So I really want to provide you with a 10,000 overview of some of the dental material that we are using here in the States. One of the goals of these lectures is to really exchange knowledge more than I will give you my knowledge. It's more to, this is what we are using here, and you will see that some of the materials, you probably have been using that for a long time. So that's me. Thank you for the nice introduction. And finally, I need to say something that if anybody listen this lecture, if you sitting there in the computer, if you want this lecture, the PowerPoint that I'm going to present, please, I will, it's so easy. You just need to send me an email. You can see the email. My email is on the screen, and you can just send me an email, and I will send you as soon as I can a link that will take you to Dropbox. Dropbox is a cloud-based storage, and you just double click, and then we'll take you to the cloud, and then you can download the PowerPoint. I promise you the PowerPoint is free of virus, so you are not going to get any virus. I super double check here. So if anybody you really don't need to take any notes. I believe the lecture is being recorded as well. So this is for everybody. And if you want to have the PowerPoint, again, you just need to send me an email to the email that you see on the screen. And you just need to say, I would love to have the PowerPoint, and I will send you back a link. Finally, and perfect. If it's any problem with the connection, because sometimes, as you know, we have been using Zoom for the last 15 months. It's almost Zoom is my best friend. I dream with Zoom, and I can imagine these days without Zoom. If something happened in the technical issues, or we have any problem, I will ask you please to send me, I have in front of me my email. You can send me an email immediately, and then we can recap. So no panic. If something happened, we will come back. And I know sometimes with Zoom things can happen. The good news is I am physically connected with the network. I'm not using any Wi-Fi. And that's one of the reasons that I decided to come to my hospital office, because if I do this from home, I will be using Wi-Fi. And sometimes Wi-Fi is the one who can make the things a little bit more complicated. So trying to avoid that, I decide to be physically connected. Finally, before we start this lecture, I want to spend a few seconds, remember all our friends and family who has died in the last 16 months because of COVID. I think so we need to realize and we need to thank you, God, that we are here alive, healthy, because in the last 16 months, I really, very good friends of mine died. I remember one, when I was back in my home country. I'm originally from Colombia in South America. I moved to the US 27 years ago. And one of my best friends in Colombia, he used to be the dean of the dental school, one of the best dental schools. He passed away. And I have several friends that I know that they died because of COVID. And we need to remember that, because I know some of you, I'm sure you have friends or you have family members that unfortunately the COVID took away their life. And so I want to remember that. We need to always keep in mind that be alive is a gift, and we don't know what will happen tomorrow. It's like that, and we never imagined a year and a half ago what will happen in our lives. I was lecturing in Manila on March of 2020. So, and I remember giving the lecture. Somebody stopped me and said, "You need to stop your lecture because you need to fly back to the US." And I couldn't understand why. And then they told me that the Philippines were ready to close the borders. This is March of 2020 when, COVID started to roll over all the countries in the world. So literally, I stopped my lecture, went to my room, packed my clothes, went back to the lobby. They took me to the airport, and then I flew back to the United States. And then, since March of 2020 up to these days, we know what COVID has been done around us. So thank you so much. We are going to start. This is the goal that we have to this lecture. We are going to trying to review one of the most common materials that we are using these days in pediatric dentistry. I know for some of you, I know that you are a faculty, and even if not, you are a practitioner. I'm sure you have a very good understanding of some of the dental material that we are going to discuss today, which is okay. I think so part of the lecture, as I said before, is to exchange more than learn, because none of the materials are absolutely new, that never in life. So I understand that. So we are going to kind of review one of the most common dental material that we are using here in my school. I need to say a few words about Dr. Mcdonald. I really don't know in Iran, but one of the most widely used textbooks in pediatric dentistry in the world. And I know because I lecture in 47 countries, and every time that I go to lecture, I ask, tell me what is the most common or the most popular textbook in pediatric dentistry. And quite often the answer is, oh, Dr. Mcdonald, Pediatric Dentistry for the Child and Adolescent. Here in the United States, for sure, is the top #1 textbook in pediatric dentistry. Dr. Mcdonald, he was a faculty, he was a dean here at Indiana University. He was one of the fathers of pediatric dentistry as a specialty. In 1955, Dr. Mcdonald, together with some colleagues here in the United States, create the specialty of pediatric dentistry. Before, pediatric dentistry was not a specialty. It was, some general dentists, they like to work with kids, and that's it. But at least here in the United States, we actually need to acknowledge that Dr. Mcdonald was the first one who stepped ahead and say, you know what, we need to create a specialty in dentistry. I have been working here at IU for the last 7 years. Before here, I was a faculty at the University of Kentucky, which is not too far from us here in Indiana. It's about 200 kilometers south of Indianapolis. So I have been working here since 2014. This is the textbook, and I am one of the associate editors of the textbook. Dr. Dean, who probably because he told me that he also gave a lecture to the Tehran University of Medical Science, is the editor, and he invited me to be one of the associate editors of the textbook together with my colleagues here at IU. So that's a dream that I never imagined I will be invited to be one of the associate editors of the textbook, and here we go. I am here, and we hope we just published the 11th edition just came to the bookshelves about 2 or 3 months ago. And we are hoping that we are going to continue the legacy of Dr. Mcdonald for the future years. So finally, I also want to mention, if you are, this lecture is about dental materials, but I'm a radiologist and I am an oral medicine specialist. So maybe in the future, we can set up a lecture in oral radiology or oral medicine in the child, which is obviously one of my favorite topics. But I just want to mention that there is a website here in the United States that we call Dr. Bicuspid. It's a website for general dentists. So you really don't need to know, you really don't need to look anything in the website. But this website invited me about 7 years ago to publish an online case in oral pathology and oral radiology every week. So I have been doing that for the last 7 years. Every single Monday, there is a new case, and each case is coming with a brief history about the patient, and then about 4 or 5 questions about the case, and then at the end is a brief review. So you want to keep sharp your knowledge about oral pathology and radiology in children, I will invite you to look at Dr. Bicuspid. So this is the agenda that we have for this morning for me, this afternoon for you. I'm going to say a few words about guidelines of non-restorative treatment for caries lesions, what kind of materials we're supposed to use. Then you can read. We go from silver diamine to sealants, something that we are using very often here in these days, resin infiltration. And I think so that's interesting. We are going to say a few words about GI or glass ionomers, resin-based composites, and finally, a few words about dentin substitutes, also something that we here are using in these days for different reasons. We use dentin substitutes for pulpotomies, we use dentin substitutes for as a liner. So we are going to talk about different things. So I hope that you are not going to get bored. If you get bored, I will be looking at you. I will be tracking your brain. Zoom is connecting Zoom with every single brain who is listening to this lecture. So if I noted that you are starting to have a flat, that means that you are sleeping. I will look at you because I see your names and okay, I have a name, iPhone. I like that name. So I see that somebody who is attending this lecture, his or her name is iPhone. I love it. That's amazing. What is your name? iPhone. I love it. iPhone. Okay. So I want to say hello to iPhone. Thank you, iPhone, to be here joining this meeting. I love it. And iPhone, I hope that you have a middle name, because if your name is iPhone, I really feel bad. I can imagine when you go, to get your passport. What is the first name? iPhone. Okay. What is your last name? Mosafari. iPhone Mosafari. Okay, whatever. Thank you, iPhone, to be here. Thank you, iPhone. Okay. So we are going to start with the first section. The first section is interesting. And I start with this slide. If a non-aerosol generating procedure is the next option. So this lecture will be different a year ago, because a year ago, we as a dentist, we were very concerned of using aerosol generating procedures in pediatric dentistry, because it was a true concern that if we use a lot of aerosols, then we can get infected, or our dental assistants can get infected, or our family who is in the room can be infected. Now, in these days, obviously here in the United States, we follow the CDC guidelines, which they are periodically updated. Just recently, about 2 weeks ago, they were updated for dentists, infection control in the dental office. So in these days, we are using aerosols. We are using high speed. We use low speed. Of course, we are using the protection that you're supposed to have. But if you have a patient who is COVID positive and you need to provide an emergency procedure, or if you have a patient that you suspect is having COVID, but you don't have an exam who will tell you, or a test who will tell you yes or not, the recommendation is you're supposed to use a non-aerosol generating procedure. Now, I need to say that even in other circumstances, here in Indiana, we are using non-aerosol generating procedures. Yesterday, I have a young kid that is going to the operative room for full mouth dental rehabilitation, but that will happen in 2 or 3 months, and difficult behavior. So in that particular child, I decide to use an option of a non-aerosol generating procedure. So in the next few slides, we are going to review briefly the recommendations in terms of dental materials if you decide to use a non-aerosol generating procedure. So in other words, if you are going to use a dental material, but you are not going to use the highest speed, period. You just decide, okay, I'm going to maybe use a spoon and I will excavate a little bit of lesion, and then I'm not going to use, for X, Y, or Z reason, I am not going to use my highest speed. So we are going to see some of these techniques. That's what we call minimal invasive restorative dentistry. So basically, I'm going to use the recent practical guidelines on non-restorative treatment for caries lesion. And if you are interested in these guidelines, probably this is the best evidence that we have, which is a publication in the Journal of the American Dental Association. This publication came in 2018. For those of you who are faculty and who are teachers and who are teaching students and residents, I'm sure you are familiar with this. These guidelines were published in 2018. It was a consensus of the American Dental Association about the use of dental materials for caries lesions without the use of high speed or without the use of low speed. The first author is a good friend of mine, and many of these authors are pediatric dentists like Dr. Juan F and Dr. Rebecca Slayton, and some of the other are more researchers. So based on this article, there are 3 questions. And remember, this is evidence-based clinical practice guidelines on non-restorative treatment for caries lesions. So you are not going to use the high speed. You are not going to use the low speed. You are just going to use a material who is provide you some help to that caries lesion. So the first question is, to arrest cavitated coronal lesions on primary or permanent teeth, what is the best option? Silver diamine, silver nitrate, or sealants? So you have a coronal caries, it's cavitated. That means that when you use, you know what is the meaning of cavitation. I'm not going to explain that. But you have a child in the dental chair with a cavitated coronal caries lesions. Could be a primary, could be a permanent teeth. What is the best option? And this is the first question who this panel of experts, they try to answer. What is the best option between using silver diamine, using silver nitrate, or just placing a sealant? So they found about 4 studies with around 2,000 participants. And then after the 30 months follow-up of these studies, they found that the best option to stop cavitated caries lesions is 38% silver diamine applied twice a year. So that means, and that's exactly what happened with me yesterday with this kid, we are going to provide care under general anesthesia in a few months. But before that, because the difficult behavior, I just decided to place silver diamine over some of these cavitated caries lesions. We are going to talk a little bit more about silver diamine and how we approach silver diamine here in the US in a few minutes. But for now, I think it's enough to say that the recommendation coming from this panel is to arrest advanced cavitated caries lesion. You need to have a good diagnosis. Remember that. If the patient is having a spontaneous pain, of course, you are not going to do this. The patient is having a spontaneous pain in a lower primary molar, that tooth is not an indication to arrest. That tooth probably will need either a pulp treatment or extraction or whatever. So 38% silver diamine was the best option. Now, to stop non-cavitated coronal caries lesions on primary or permanent teeth, what is the best option? And there is a lot of different options. Sodium fluoride, APF, amorphous calcium phosphate, casein phosphopeptide, silver diamine, resin infiltration, sealants, or carbamide peroxide. So the authors, the panel of experts, they found 8 studies, including about 726 participants, and they divide the recommendations in occlusal surface and interproximal surfaces. So for occlusal surfaces, to arrest or reverse non-cavitated caries lesions on occlusal, non-cavitated on primary teeth, the best option is to use sealants, 5%. What happened?
Sorry, are you just going on the slides? Because we are just saying the first, your first slide, which is new frontiers in dental materials to use. Are you moving on?
Yes.
Yeah, but we do not see the slides.
Yes, I am moving, absolutely.
Yeah, but we are on the first one. We are just stuck on the first one.
Yes, I am moving. Absolutely. I
think you should get back so that we see the movement of the slides because you're stuck.
Okay, I go back. Well, thank you. You see?
Yeah, that happens. Now we have practical guidelines on non-restorative treatments. Now cover story.
Okay. Okay. Well, thank you.
Well, thank you so much. Sorry for interrupting.
No, you need to interrupt me when that happen. Absolutely. Absolutely. You need to do it. I don't want to be talking in the same slide. That would be so boring. I can imagine everybody will go and eat and come back. So I was talking about this article, and I will go quick here. And please just give me a thumbs up or thumbs down if you don't see the slides moving. Absolutely. So this is the article that I was talking about it, the evidence-based clinical practice guidelines on non-restorative treatment for caries lesions. So I talked briefly about the 3 questions. The first question was to stop cavitated. And I said that I'm not going to explain the meaning of cavitated. We all know what is the meaning of that. So to stop cavitated coronal caries lesions on primary or permanent teeth, what is the best option? The best option based on this systematic review is the use of 38% silver diamine twice a year. Then the second question was to stop non-cavitated coronal caries lesions on primary or permanent teeth. What is the best option? And they discuss all these potential alternatives: silver diamine, APF, polyols, amorphous calcium phosphate, casein phosphopeptide, silver diamine, resin infiltration, or carbamide peroxide. So the recommendation was for occlusal surface, the best option is to use sealants. This is interesting. When I was in dental school, I went to dental school, and then after dental school, I went to medical school. So I'm a dentist first, and then I went to medical school. So in my days in dental school, this is 1992. Some of you were not born. I think so. The idea was you cannot place sealants over dental caries, period. I can imagine at that time, if somebody will come to a lecture and say, hey, you know what? We can place sealants over non-cavitated caries lesions. I think so that person will be fired from the dental school in the 90s. The idea is you cannot place sealants, but obviously the time changed. We have more knowledge. So to stop non-cavitated caries lesions based on this review, probably the best option, according to the authors, is the use of sealants plus 5% sodium fluoride varnish every 3 to 6 months, or sealants alone over 5% sodium fluoride alone, or something that we are going to talk later on, resin infiltration. Now, to arrest or reverse non-cavitated caries lesions on occlusal surfaces on permanent teeth, the best option is pretty much the same: sealants plus sodium fluoride, or sealants alone, or sodium fluoride alone, or resin infiltration plus sodium fluoride. Finally, interproximal lesions. What is the best option? So based on this panel, based on this group of experts, to stop or reverse non-cavitated caries lesions on interproximal surfaces in primary or permanent teeth, 5% sodium fluoride varnish every 3 to 6 months, or resin infiltration alone plus 5% sodium fluoride. And again, part of this lecture is we are going to discuss resin infiltration. So we are going to talk a little bit more about that. And finally, for facial or lingual surfaces, non-aerosol generating procedures to stop or reverse non-cavitated caries lesions on facial or lingual, primary or permanent teeth, the best option, interesting, according to the panel, was 1.23% APF gel every 3 to 6 months, or 5% sodium fluoride. Now, one of the good things about this article that is free to download, so you can go to the Journal of the American Dental Association website and you can download this article. At the end of the article, there is a nice algorithm. Remember, this is non-aerosol generating procedures. So this is when you don't want to grab your high speed or your low speed for whatever reason you have in mind. So this is the algorithm for primary teeth. So you have dental caries, occlusal. Then you can go to the left side of the picture. If it's non-cavitated, you can see the options. If it's cavitated, the best option is silver diamine 38%. If it's proximal, if it's non-cavitated, you can read the options. If it's cavitated, again, you go to silver diamine 38%. I found myself a little bit challenged to place silver diamine in between the teeth. Some of my colleagues, they kind of paint with the brush in between the primary teeth, and then with a floss, they kind of introduce the silver diamine in the interproximal area. I prefer to use resin infiltration, and we are going to talk in a minute. And finally, on the right side, if you have decay, facial or lingual, if it's non-cavitated, 1.23% APF gel or 5% varnish. If it's cavitated, again, you go back to 38% silver diamine. And this is the same algorithm, well, for permanent teeth. And that's it. That's what I have for non-aerosol generating procedures. As a faculty here, I always like my residents to be very aware of this article, because this article provides evidence-based guidelines for the treatment of cavitated and non-cavitated caries lesions in children in permanent or primary teeth. And that's important to keep it in mind, because sometimes we don't want to grab the highest speed. I know in these days for COVID, but could be other reasons why you don't want to go ahead and drill, or why you don't want to go ahead and remove using low speed or high speed the caries lesion. Okay, we are going to keep moving into the agenda. The next topic is silver diamine. I need to be careful here, because I unfortunately, I didn't ask before. I don't know for how long you have been using silver diamine, and it's probably for a long time. Here in the United States, the use of silver diamine is still part of the new frontiers. So if you are an expert in silver diamine, please forgive me. You just need to kind of go and grab something for the fridge and come back and drink a glass of water, or just relax having tea or having coffee. And then just wait until I start the next topic. So depending on your knowledge, you can just take off and come back. One of the issues with this lecture, which I mentioned before, is I don't know the previous knowledge. This is kind of new frontier. So I don't know how expert you are. And maybe some of you are super experts in this topic. So I don't want to kind of give you the idea that I am the absolutely expert, because I am not. I just want to share the use of these dental materials, how we use it here in the States. And maybe you will say, well, here in Iran, we do exactly the same. So we are in the same page. Or maybe we use it in a different way. It doesn't mean that you are good or I'm bad, or I'm good, you are bad. It's just simple that we have different ways to do the things. So silver diamine fluoride. So silver diamine is commercially available as a silver salts for caries management. Here in the United States, we have two different silver salt products available to use for caries management. We have the silver nitrate solution at 25%, and we have the silver diamine fluoride solution at 38%. So these are the these two silver salts are approved here in the US. In our neighbor, Canada, silver diamine was approved in February of 2017. Here in the United States, it's interesting how silver diamine became available too late. Silver diamine has been available in many countries in the world for a long time. In March of 2015, the Federal Drug Administration decided to provide approval for the use of silver diamine as a medical device for the treatment of tooth hypersensitivity. So it was not approved for the treatment of dental caries. Silver diamine is not recommended for the use here in the United States of patients under the age of 21. I know it's kind of crazy that we are using silver diamine off label. And the reason that it's not approved by the FDA for the use of children is because there is not enough evidence of the potential side effects in the systemic approach for kids. So because there is not enough evidence at the federal level here in the US, they decide, okay, we are not going to approve silver diamine for kids, just people 21 and older. However, we use silver diamine. So silver diamine is, as you know, is a clear solution. The pH is between 8 to 10. It's a metallic taste. Sometimes you need to be careful, as probably you are using silver diamine in Iran. You need to be careful because for some kids, the taste of silver diamine could be very disruptive. As you know, kids, they sometimes make a big deal about everything. So it's a metallic taste. This is the composition of the silver diamine fluoride at 38%, which is the one that we have available here in the US. Silver is about 24%. It's interesting, and I ask this question to my residents all the time. Hey, what is the percentage of fluoride in silver diamine fluoride? 38%. So they look at me, that's, of course, it's 38% fluoride. Well, that's wrong, because the concentration of fluoride is not 38%. The concentration of fluoride is about 5 to 6%. It's not 38%. So I know silver diamine fluoride 38% is misleading in terms of the amount of fluoride. So the amount of fluoride is pretty much the same amount of fluoride that we have in sodium fluoride 5%. The difference is, of course, we add silver, which is really the antimicrobial antimicrobial, pretty effective component of the silver diamine, and water is about 60%. So we have some caries management challenge. If you are a pediatric dentist, you are with me in the same page. You know that sometimes it's difficult to provide caries management to young kids, to all patients, medically compromised, and uncooperative patients, maybe too young. Sometimes we have, very often, you are going to get surprised. Here in the US, very often I have 2-year-old, 1.5-year-old, as soon as the baby front teeth are in place, the primary teeth are in place, immediately they get decay. So it's difficult to provide dental caries management using a high speed in a 1-year-old and a half moving in the dental chair. So with this challenge, I think so silver diamine came as a good helper. Or sometimes we have caries lesions in this patient with cleft palate, in places in the mouth who is very challenged to access. So in this situation, silver diamine is a good helper. So the management of early childhood caries, there is no recognized standard of care. We use different ways. Here we follow the reference manual for the American Academy of Pediatric Dentistry. And unfortunately, and I say unfortunately, here in the States, we have this idea that we need to take every single child to general anesthesia. And that sometimes could be an issue because, as you know, number one, GA is not free or risk. So when you decide to take a child to the operating room, that comes with some risk, and sometimes we don't think about it. And the other issue is expensive. It's expensive for the health system. It's expensive for the families. And sometimes, you know, some of these teeth, they may not need to, you know, provide treatment. So there is not really a standard of care. What is the best way to manage early childhood caries? And as you know, unfortunately, we have terrible accidents in the OR once a while that kids are taken to the OR, and unfortunately, serious complications happen when the kid is under general anesthesia. A little bit about the silver salt, which is a component of silver diamine, has a strong antimicrobial activity. Silver is not just only used for silver diamine. Silver is also used in many different products, from water lines management to home cleaning clothes. It's a very strong antimicrobial product. The silver nitrate is the component of the silver diamine. It's the less expensive salt of silver. It's commercially available in different concentration. And that's the reason this lecture is not new frontiers, because the silver nitrate had been used for over 1,000 years in different medical applications. This slide is just a brief history. I'm sure you are aware of this. I had the opportunity to spend almost 6 months of my life in New Zealand before COVID, doing an externship in Christchurch, New Zealand. And it's interesting, in New Zealand, they have been using silver diamine for 90 years. I mean, they really, so when I came back to the US, it was a surprise that that we were in the process to trying to get the approval for silver diamine when other countries have been used for a long time. This is how silver diamine kills the bacteria. Remember, I mentioned that silver diamine has a strong antimicrobial component. And why that antimicrobial component? Well, silver interacts with some of the proteins who are in the DNA of the bacteria. So if Juan F is a bacteria and you paint myself with silver, I will die. All my DNA will disrupt and break down and I will die. Also, if I'm a bacteria and you paint myself with silver diamine, I will stop the respiratory cycle, which is important to generate calories in order to produce energy. Also, silver diamine stops the cell wall synthesis. And finally, silver diamine inhibits the DNA cell division. So if I'm a bacteria and you put silver diamine over me, I will die, period. It's a pretty strong antimicrobial. Just for this lecture, I decided to do a brief lead review about silver diamine, just to try. I can spend 2 hours just talking about silver diamine, but I just decided to put some articles that I think is important. I know some of you are faculty, and I think so we as a faculty, we're supposed to be updated and we're supposed to be pretty sharp about the front line of the literature. So just a few sentence conclusion of some of the articles. Remember, this lecture is your lecture. I can share the PowerPoint. Definitely 38% silver diamine is better than other lower concentrations of silver diamine. Here in the United States, you can also find silver diamine at 25%. But definitely, the articles that we have available, the conclusion is 38% solution is better than the 25%. There is one more kind of a little quote. If you decide to use silver diamine, there is no advantage to excavate the caries. And that is in the same page with the first part of this lecture about non-aerosol generating procedures. So if you decide not to use silver, if you decide to use silver diamine, you really don't need to excavate the caries, or you really don't need to use high or low speed. There is also a conclusion of some of the articles. It's better to reapply silver diamine rather than just one time. And that's exactly what we do here in the United States. When we decide to use silver diamine, we like to see the patient 4 weeks later. And depending how we see that the patient is, the response to the silver diamine, we sometimes reapply silver diamine. Recently, about 2 months ago, I published an article in Pediatric Dentistry, which is the article, the journal of the American Academy of Pediatric Dentistry, about the use of silver diamine in the United States. We use dental claims, which is what we submit as a dentist to the insurance companies to get paid. So I look at dental claims of dentists using silver diamine 1 or twice, and we found that the majority of US dentists are using silver diamine twice. So you apply silver diamine, and then 4 weeks later, 4 to 8 weeks later, you bring the patient back, and then quite often they reapply the silver diamine. And we know that because you submit a claim. That means that you want to get paid. So we are still having some questions about silver diamine. What is the optimal protocol for applications? What's supposed to be the reapplication rate? Caries prevention versus arrest or stop? What is the long-term effect, or how, in a long term, how silver diamine will affect the bacteria in the mouth? What is the cost savings? That's a very hot topic here in the United States. It's less expensive to use silver diamine than just go ahead and do a conventional restoration. So some dentists, they are against the use of silver diamine, because if you do that, then you don't have the opportunity to do the full restorations and bill for the full restorations. The American Academy of Pediatric Dentistry, they have a evidence-based dentistry committee, and they developed some guidelines about the use of silver diamine that I just want to share with you. I'm sure you are aware of that. So these guidelines were published in the journal. The journal is Pediatric Dentistry about 2 years ago. And the way that they developed the guidelines was using the PICO guideline approach. And basically, the PICO means that you need to have a question, and you go to the literature and try to answer the question. So the question was, does the application of silver diamine stop cavitated caries lesions as effectively as other treatment modalities in primary teeth? Other treatment modalities means high speed, low speed, amalgam, composite, or whatever you want to do. So this is the recommendation. I'm sure you know this article by memory, because this is one of the articles that we teachers, we need to be fully aware, at least here in the United States. This is the guidelines: use of silver diamine fluoride for dental caries management of children and adolescents, including those with special healthcare needs. And the recommendations is in the bottom. The silver diamine panel supports the use of 38% silver diamine for the stop of cavitated caries lesions. Cavitated, interesting. Caries lesions in primary teeth as part of a comprehensive caries management program. I need to be careful here, because here in the United States, here, and I don't want to say I agree or disagree, I just want to say here, we don't see silver diamine as a final treatment. And that's one of the good things about having this kind of conference, Zoom conference, because that means that we don't see the patient apply the silver diamine, and then we say, goodbye, my friend, you don't need to come back. We see silver diamine as a comprehensive caries management program, as an intermediate step. That means that I apply silver diamine, and then in my mind, in 3 months, 6 months, a year, I'm planning to do something else. And that is important. It doesn't mean I agree or disagree and whatever, but we don't see the application of silver diamine as the last treatment. This is from the article. They review all the different articles. If you are my doctoral degree is in epidemiology, so I love to look at confidence intervals, and I love to look at the quality of the articles used for these recommendations. So as you expected, the quality of the articles used for these recommendations is not the best quality. Because maybe few patients, maybe because the following time was too short. So at the end, the quality assessment of the literature used for this recommendation was not too high. And this is a little bit closer, the articles that they use. This is also one more article that I love it, published in Caries Research, which is a pretty high impact factor. It's one of the best journals, if not maybe the best in Caries, obviously, research. Silver diamine fluoride, efficacy in controlling caries progression in primary teeth. And they found, you can see the plot analysis on the right side that is over the right side. So the article that they look favors the use of silver diamine to stop cavitated or non-cavitated caries lesions. This is one more article I'm going to skip, and some of these slides I'm going to pass a little bit quicker so we can cover what we're supposed to cover. And then if you want to go in more detail, you have the PowerPoint available. This is one of the best articles, I'm sure you are aware. This is published in the Journal of Dental Research, the highest impact factor journal in the United States. Basically, randomized clinical trial of 12% and 38% silver diamine fluoride. And they found that 38% much better than 12% silver diamine. A little bit of the pharmacokinetics of silver diamine. And I don't think so. A patient is going to ask you this, or a mom is going to ask you, hey, Dr. Yepes, can you please tell me the mean silver diamine solution concentration after 1 hour that you apply the silver diamine? I don't think so, but if you want to know, here we go. So silver diamine advantage, control of pain, is no invasive, control of infection. That's one of the positive things about the material. Easy to use, it's affordable, it's not too expensive. Minimal time for application, no question about that. I want to say this in capital letters. Here we go to all my colleagues, including iPhone, which I hope is still listen this lecture. And I tell this to my colleagues, and I tell this to my students and to my residents. Silver diamine is not a silver bullet. It doesn't mean that you can use silver diamine with everything. We still need to use the brain. Case selection is critical. That means that if the patient is having a spontaneous pain, or if the caries is encroaching the pulp, that patient is not a candidate, or that tooth is not a candidate for the use of silver diamine, period. So we need to be good clinicians. Silver diamine is not to use in every single case that we have. We need to have the parents and patient consent, and they need to be okay with the tooth staining. So these are the goals of the treatment of silver diamine: stop caries, prevent delayed surgical treatment, stop caries progression. And this is what I mentioned before. Here in the United States, when we use silver diamine, we are looking at what we are going to do after that. So it's not the idea to tell the patient, I apply silver diamine, that's it. So after silver diamine, we are always looking to place something. Either I'm going to put a crown later on, or I'm going to put a liner, or I'm going to put a cement, or whatever I'm going to use. So we don't see silver diamine as the end treatment. The clinical application, I'm sure everybody listening to this lecture, you are fully aware of the technique. It's important to inform consent to the patient to wear gloves, paper tray cover to protect counter surfaces before dispensing only 1 drop of silver diamine solution. We isolate the tooth with cotton rolls. Then we just moist the caries lesion with the smallest amount of silver diamine solution possible using a microbrush. And be careful not to touch intra or extraoral soft tissues with the microbrush or the solution. We don't like to apply more than 5 teeth in one session. So if the patient needs multiple teeth, more than 5, we prefer to split that into different sessions. Follow, we leave the teeth and restore. We don't like to do that. Silver diamine is not going to give you back the morphology of the tooth. And this is true here, and I'm sure it's also true in Iran. And it's also true in many countries and many dentists around the world. We need to keep in mind that we have teeth in the mouth to chew. I know it sounds crazy, we are dentists, but sometimes we don't remember that. We have teeth in the mouth because we need to put food, and then we need to chew the food. Now, why I'm saying that is because you can apply silver diamine in a primary molar with a huge occlusal cavity, and you can arrest or you can stop the cavity, but that tooth is not going to return to the function, which is chewing. And here and I have this discussion with all my residents and my colleagues. You can just apply silver diamine in a huge occlusal cavity, but the dentin is not going to regenerate. The enamel is not going to regenerate. So what is your job? Your job is to make sure that at some point that tooth will return to the function. And the way to return to the function is you need to place a restoration who is going to give back the form to the tooth so you can use it for chewing. So you can place a stainless steel crown, or you can place an amalgam, or you can place whatever you wanted. So follow the treatment. Now, if in some situations, very specific situations, is not possible to place a restoration over the tooth, then you need to follow the patient very close. So to finish and to close here, we always see silver diamine as an intermediate treatment. So the take-home message is silver diamine 38% is better than lower concentrations. Biannual application is better than just once a year. And probably the last bullet, silver diamine is part of a comprehensive caries management program, but there is no, obviously, a silver bullet. So we are going to say a few words about the whole technique. The whole technique is very close here to my department here in Indiana, because we advocate here in the United States a lot about the use of the whole technique. In fact, we got a lot of controversy and we got a lot of fire. A few years ago, we published an article in the Journal of the American Dental Association about the use of the whole technique. And we have a lot of backfire from dentists saying that the whole technique is not an appropriate way to approach caries in children. But here in Indiana, we strongly believe that the whole technique is an option. We are just, we develop different projects of the use of whole technique, and we truly believe that the whole technique is an option. So the whole technique, as you know, I don't know if you are using that in Iran or not, I'm sure you are using the whole technique, is basically you place a stainless steel crown in a tooth with a caries lesion that is not having a spontaneous pain, and the caries is not at the pulp chamber without any prep. You just squeeze the crown over the tooth. I know it sounds crazy. When I hear from the whole technique for the first time, I couldn't understand how you can squeeze a crown without opening the mesial contact. Like in this case, how do you squeeze a crown without opening the contact between the second primary molar and the first primary molar? Believe it or not, you can do that. And if it's just one tooth, we publish at least 2 or 3 articles about the whole technique in the last 5 years. You can even leave the crown a little bit in over occlusion, a little bit higher. And then when the patient comes back a few days later, you will see that the crown is finally sitting in the place. So the whole technique is not from us. It was developed by a Scottish dentist, Dr. Norma Hall. That's the reason that we call the whole technique. And she started to use stainless steel crowns to treat decaying primary molars without any treatment in Scotland. So then, you know, the Scottish, they start to use, imagine, since the 80s. So they start to use very often the whole technique, and they publish a manual, which we use it here. This is what we use. The whole technique, a minimal intervention child-centered approach of managing caries primary molars. So this is what we use here. So as you can see, you basically squeeze the crown. Personally, I found relatively easier to do the whole technique for the first mandibular primary molars. I found a little bit more complicated to do it for the first maxillary primary molars, and very complicated to do it for the second primary molars. That's me. Now, if you talk with Dr. Dean, who is one of my colleagues here, he will say that it's super easy to do it in any tooth. I don't know how he does that. So I think so this is also operator dependent. Some people, some dentists are more talented to do this without any prep. Now, doing back-to-back crowns, first primary molar and second primary molar, I found that extremely challenging. So I always try, and that's me. Now, other dentists, I'm sure you can do it, but for me, it's very challenging to fit 2 crowns without any prep. So as you know, there are plenty of studies that shows that the whole technique is a very effective technique. So if some people is having some concerns about the whole technique, I just want to tell you that the literature clearly demonstrates that the whole technique is a pretty interesting approach. there are several studies. This is one, 2-year results from 124 teeth treated with the whole technique compared with 124 conventional restorations. So doing the conventional technique in a split mouth study, they found that the majority of the failures were in the conventional technique rather than in the whole technique. So that is interesting. Just thumbs up if the slides are moving. Okay, perfect. So this is from the same article. When they look at the patient dentist preference, obviously the dentist in this study that was in Scotland, they prefer the whole technique. The parents, they prefer the whole technique because you don't need to numb. And the kid obviously prefer the whole technique. This is a different study. Children show least negative behavior in the whole technique group compared with the conventional and compared with other techniques. At 1 year, this is also one more study, 98% of the whole crowns were successfully. So if you believe that when you place a crown using the whole technique, the crown is not going to stay there, well, the literature shows you that yes, it's going to stay there. So the whole technique typically provides no caries removal, no local anesthesia, no preparation. The studies show better outcomes, no question about that, even if you don't believe in this technique. Unfortunately, I have bad news for you. The literature tells you that the whole technique works as good as the conventional restoration. The literature also tells you that there is no significant difference between whole technique and traditional. A whole technique crowns sometimes open the occlusion, but that returns to the pre-treatment levels in 15 to 30 days. More negative behavior in children who receive the conventional technique. And in 2015, a review showed that there is a good quality evidence that favor the use of the whole technique for stainless steel crown placement. So I have plenty of examples. I don't want to really show you hundreds of slides about that, but this is our examples. I feel very proud of my colleagues who are super good placing, especially the first primary maxillary crown. In my opinion, it's extremely difficult to put that crown, but they did it. This is the study that we published here in Indiana that we got a lot of backfire from dentists who they don't want to accept that you can place a crown without any prep. So we published this in 2014 in the Journal of the American Medical Association, Dental Association. We compare the whole technique compared with the conventional technique. We did a retrospective chart review. A whole technique, 97% successful. That's amazing. Conventional, 94 successful. So it was better, the whole technique. The conclusion was similar success rate for either technique, either conventional technique or whole technique. This is a study that we just submitted to the International Journal of Pediatric Dentistry and was accepted. So it's coming, I believe, in a couple of months. We did a radiographic marginal fit analysis because that's one of the concerns of the dentists who are crazy of the conventional technique, that they hate the whole technique. They always say, well, when you do the whole technique, you are always going to have a pretty bad marginal adaptation of the crown if you decide to follow the whole technique. Well, we look at that. We compare two different dental practices. My practice, my private practice, who I usually 90% of the time, I use the conventional technique. We compare my practice against the practice of one of my colleagues who 90% of the time he uses the whole technique. So we went to my office, we review 100 kids that we place crowns using the conventional technique, and 100 crowns that my colleague, he placed the crowns using the whole technique. And we look at the radiographs and we found no significant difference in terms of the marginal adaptation, regardless if you use the whole technique or if you use the conventional technique. So for those who are very strong, telling that if you use the whole technique, your margins are going to be horrible, I'm sorry to tell you that the evidence shows that the margins are going to be as close as the margins when you use the conventional technique. Now, why I still using the majority of my cases, or the majority of my patients, I still using the conventional technique, because I found quite difficult to place that crown, especially for the first maxillary primary molar. It's challenge. And when I try to use it, some of my colleagues, what they do is they place separators, ortho separators, and then they bring the patient back, and then they squeeze the crown. I found that now for the first mandibular primary molar, I can do it. We are going to say a few words about sealants. I'm going to stop for about 5 minutes, going to have a kind of a water and going to have something to drink. So just give me 5 minutes and I will come back here and we'll continue. We are about, we are going to talk, the good topics are coming in a minute. So just give me 1 second, okay? 1 second will take me, I'm going to stop the share here, but I'm going to come back. It will take me about 5 minutes break.
Yeah, that's fine. Thank you.
Okay, I'm back. So we will continue the lecture. Thank you for this. My voice is, my saliva is getting low, so I come back here.
Thank you so much, Dr. Yapas. One of our participants asked us, wants you to show the slide showing the non-restorative technique before starting again, if you wish to, or you can get it back to it after finishing your speech.
Yeah, I can get it back when I finish if you want it.
Yeah, that's great. Thank you.
Okay, I'm going to, again, please let me know if it's any reason, any problem with the PowerPoint, okay?
That's fine. If you please start sharing the screen. Yeah, we have the slide.
Okay, can you see it?
Yes, and then we have to check the movement.
Yeah, we need to check the movement. That's right. It's moving?
No, it's yeah, it started. Yeah.
Okay. Okay, so we will continue. And what we are going to do now is, so I just kind of give you a review. We talk about guidelines of non-restorative treatment based on one article that I think so is important for us as a pediatric dentist or dentist to be aware of what is the best evidence for the treatment, non-restorative treatment of caries lesions. I think so that's an important concept that we need to keep always in mind, because 20 years ago, we didn't have that. Then we have a brief review of silver diamine fluoride. Then we have a brief review of the whole technique. If you want more information about the whole technique in terms of articles and literature, here in Indiana University will love it. So I am more than happy to provide any additional information that you want about that. So now we are going to move to sealants. I want to just make an announcement here. With sealants, I'm going to be really to the point. I don't want this lecture to be a lecture about the use of sealants, because everybody listening to this lecture, you are an expert of sealants. So I just want to provide with a brief review of sealants and a couple of no new things, but a couple of things that we use here in the US. And that's fine. It will take me about 5 minutes to go to sealants. So just sit down and relax. I'm sure you are an expert in sealants. So some of the slides of sealants are very heavy in terms of information, which I usually don't like to have that. So forgive me about that. But usually you will see within the slide, there is a yellow sentence. And that yellow sentence, or highlighted, is really the take-home message of that particular slide. So rather than reading the whole slide, I'm going to concentrate in that take-home message. And that will make this section a little bit more practical in terms of what is the really important knowledge about sealants. We have been using sealants for a long time. So isolation is the key. If isolation is a problem and you cannot provide a correct isolation, you are fully aware that probably the best alternative is to use GI, glass ionomers. But if you can provide a good isolation, here we are using these days, we have different systems available to do isolation. In the old days, rubber dam, it was probably the only alternative besides just using fingers and cotton rolls. But in these days, we are using something that we call Isolite, and also something that we call dry shield, which are different, almost like a plastic device that we put inside the mouth of the patient. And by the way, I forgot to say something. I don't have any conflict to disclose. I am not here paying by any company. I'm not here receiving any kind of honorarium, nothing. So that's important, and I'm supposed to say that at the beginning of my lecture. The picture on the top right is the one that I'm using these days. We call dry shield. The one on the bottom right is Isolite, and the one on the upper left is Mr. Thirsty. That's an amazing name. And then on the bottom, we have rubber dam. So a little bit of the epidemiology of dental sealants, or why it's important to learn about dental sealants. 90% of the caries in permanent teeth of children occurs in pits and fissures, and about 2/3 occurs in the occlusal surface alone. Occlusal decay accounts for about half of the caries in primary teeth. So I'm not going to talk about the etiology of the caries. I don't know, and I think so that would be an interesting discussion, what kind of classification you use in Iran. I guess you probably use the ICDAS, the International Classification of Dental Caries. Here in the United States, we use the classification of the American Dental Association. So, and you can go here in the bottom, it goes from non-cavitated initial lesion. So that's the initial caries lesion development before cavitation occurs. And then it goes to the right side, which you can see on the bottom of the slide, which is the advanced mineral loss or cavitated caries lesions. So this is a nice picture that compares the ICDAS classification compared with, it's interesting, here in the States, we are not very fan of the ICDAS classification. Not many dentists use the ICDAS classification. Interesting, in our graduate program, we don't use the ICDAS classification. We don't use it. So we use more the clinical presentation, sound, initial, moderate, and advanced. And that's how we classify the caries. And you can see in this slide how that compares with the ICDAS 0, 1, 2, 3, 4, 5, and 6. So this is the guidelines sealant panel recommendation from initially 2005, but was updated in 2014 and recently was updated again from the American Dental Association. I think so. Some of the important kind of conclusions of all these updates of the recommendations of use of the sealants is the number one, we use sealants in primary teeth. I know a couple of years ago, using sealants in primary teeth was not recommended, but the last American Dental Association guidelines for the use of sealants include sealants in primary teeth and also permanent molars. So we are using sealants in primary teeth. Before was the idea that the adhesion of the sealant in primary teeth was not as effective as permanent teeth. But in these days, there is enough evidence that the American Dental Association recommends the use of sealants in primary teeth as well as permanent teeth. The problem is insurance companies here in the US are not really ready to pay for that. So when we submit a claim of a sealant in a primary tooth, very often the claim gets rejected. So it gets back to us. Either we have the option to charge the patient or the parents, or we just do that as a gift. So that's the problem. Sometimes the time between the guidelines and the insurance companies to get that included in the payment plan, it takes years. So far, up to today, we place sealants in primary teeth. We have been doing that for the last couple of years, but 90% of the time, we don't get paid for that unless you charge to the families in front and you say, we are going to put sealants in primary teeth, it's not going to get paid, so by your insurance company, you need to pay in front. Here in my office and here at the hospital, 90% of our patients are covered by insurance, by dental insurance. So the majority of our patients are paid by a third party. Only the minority of the patients are self-paid. Also, something that we always do here is we always place bonding between the sealant and the edge. So we edge, and then after the edge, we place bonding, we cure, and then after the bond, we place the sealant. And this is backed up by the guidelines of the American Dental Association, as well as the guidelines of the American Academy of Pediatric Dentistry. So in conclusion, in terms of sealants, we use sealants in both dentitions, primary and permanent. And the other conclusion about the sealants, and this is based on the panel recommendations, is in terms of the retention of the sealant, is better when you place a bond between the sealant and the edge. The routine mechanical preparation is not anymore recommended. So we don't provide any mechanical preparation of the tooth before we place the sealant. When possible, four-handed technique should be used, obviously, to try to keep that tooth dry. And we also, when we place sealants, we follow the suggestion that the use of the explorer is not necessary for the detection of early lesions. So we agree that the detection of early lesions is a visual detection. How effective are the sealants? This is all article. Based on this article, insufficient evidence to support the use of fissure sealants in primary teeth. This was actually reevaluated in the last guidelines 2 years ago, that they decide that yes, we have now new evidence that support the use of sealants in primary teeth. If you are using, I'm sure in Iran, you are using in some circumstances when isolation is very challenged, I'm sure you are using glass ionomers. We are using glass ionomers here as well, but the evidence shows that when you use glass ionomers as a sealant, the retention of the GI is not as good as the retention of the regular sealant. So if you decide to use GI because you have an isolation issue, like you have a patient with high caries risk and you want to place sealants in the actually partially erupted permanent molars, when really doing a good isolation is almost impossible, and then you decide to use a GI, which, as you know, they are less sensitive to moist, so you can use the GI as a sealant, you need to be careful because in terms of retention, that probably will be not as good as using the traditional sealant. I don't know how often in Iran you get the comment from the families about the safety of the sealants. And here, once a while, some moms and some dads, they will look at my eyes and they will tell me, I don't want you to place sealants in my child. So I open my eyes and I say, why? Can you tell me why? And then sometimes parents, they go to Google and they go to Yahoo or whatever they use as a source. Sometimes, as you know, there is a lot of misinformation. In fact, if you type in Google, I want to get vaccinated for COVID, you will see that some websites that will tell you that in the vaccine, there is a microchip that is going to be injected in your body, and then the government is going to take control of your life. So there is a lot of misinformation. And I think so in dentistry, we have two issues that comes to us quite often. One is the BPA, which is one of the bioproducts of sealants and potential issues. And the other issue that comes once a while is the application of fluoride. Some parents are against the fluoride because, as you know, and we can have a whole lecture, 2 hours about the fluoride, there is some evidence of potential toxic effects of fluoride, including babies. When you use fluoride in moms who are pregnant, apparently the fluoride will have some potential side effects in the babies. The evidence is not at all strong. So the BPA is the one that sometimes we deal. So what happened when you have a parent who tells you, please don't place sealants because there is some issues with the BPA. And we have sometimes that here in the hospital as well as in my private practice. So the reality is, this is the American Dental Association statement of BPA. The dental materials, they really contribute very low to the BPA exposure. BPA is now used as a formula ingredient in dental materials. What happened is the BPA can be released in very small quantities as materials are broken down by salivary enzymes. BPA is a trace material left over from some bis GMA and bis DMA, which are some of the components of the sealants, as well as composites. So the residual BPA that is not fully converted to these ingredients can be found in dental composites. In 2015, the American Dental Association updated the technology to look for BPA in parts per million in dental sealants. They found BPA in many common dental products. Now, the Federal Drug Administration, they place a maximum amount of BPA. So in order to exceed the FDA safe exposure limits in a 15 to 18 kilos child, you will need to consume about 1 million to 3 million of syringes per day of raw unpolymerized sealant composites. So clearly, in order to provide an amazing amount of BPA to the point that is going to cause some toxic effects in the child, you will need to give between 1 million to 3 million syringes of raw unpolymerized sealant composites. Once the composite is polymerized, there is virtually no release of BPA. We did one study here in Indiana last year using a very interesting technology to measure the amount of BPA parts per million in patients. So we place sealants in about 200 kids, and then we collect saliva samples over 2 months period. And then we look for BPA in 2 months after we place 4 sealants in all the first permanent molars, and we follow the kid with saliva samples every other day for over 2 months. And every sample, we process the sample to look for BPA, which took forever, very expensive study. The conclusions, you can find some traces of BPA the first 24 hours after you place the sealant, but then in the subsequent samples, we couldn't find any BPA. So how you can limit the amount of BPA, if that's a concern, how you can limit the amount of BPA? Well, probably the best way is to ask after you place the sealant to do the polymerization using a light with the correct light intensity to polymerize the sealant. And then you can kind of do a rinse with water suction, rinse with water suction, and then you can really decrease the amount of BPA that you can give to the patient. So this is the composition of sealants. I'm not going to do that. The glass ionomers is suggested when isolation is difficult. I place GI often when isolation is challenged. So I like to protect that tooth, not wait until the tooth is fully erupted. So we place this, the GI. It's important also, I don't know how often, if you are a teacher, I don't know how often at the dental school, you check the intensity of the lights. That's an important factor in the polymerization of the sealant. We do that every 6 months. So we have a special device that we check all our lights. Interesting, a few years ago, one of our residents, he did a study looking at the intensity of the light every 6 months. And you are not going to believe, but very often the light curing lights, they kind of lost a little bit of the intensity with time. We found that after a year and a half, that light is not providing the intensity light that you need to cure the sealant. So the light intensity should be periodically checked with the device, and the minimal output is 350 milliwatts for a square. That means that the minimal intensity that you need for the light cure in order to polymerize the sealant. So the adequate polymerization is a function of the energy delivered to the resin. So depth of the cure lower in darker composite shades. So that is, I don't want again to read this, but it's important that you make sure that you polymerize the sealant appropriately. The technique, everybody listen to this lecture, I can imagine at that point in your life, if you are not an expert how to place the sealant, so I'm not going to do that. Isolate, we use the edge. And then after the edge, we use the bonding, and we always use that. And then we bond, and then we place the sealant. And this is what I mentioned about making sure that the light is giving you the intensity that you need it. Okay, we are going to talk about one of my favorite topics these days that I'm using all the time in my office. We use that all the time here in the hospital. I think so this is really new frontiers. Out of everything that I'm talking today, I think so the resin infiltration is by sure one of the new frontiers that I wish when I was a child and my mom used to take me to a dentist. I never went to a pediatric dentist. My mom always, she took me to a general dentist who was kind of a cousin of my mom. So it was a family relationship. And he was just a general dentist. And why I wish resin infiltration was available at that time? Well, because I have plenty of class 2 restorations in my mouth that then later on they ended up in crowns, and then I have one who already ended up in root canals. So the resin infiltration is fantastic because it's a non-invasive, you don't need to use high speed, perfect alternative for incipient interproximal lesions. That's amazing. I never thought that in dentistry we will have resin infiltration available, because what I learned in dental school, and I'm sure everybody listening to this lecture, what you learn is if you have an interproximal caries lesion, what is the only way to provide treatment? Well, you take the highest speed and then you make a hole and then you make a cavity, a DO, distal occlusal or mesial occlusal or whatever, and then you play the restoration. But you know, as well as me know, as I know, that restoration, even if you are the best dentist in the planet, at some point, the restoration will fail. So resin infiltration came here about 4 or 5 years ago. We started to use it. We kind of, okay, at the beginning, we thought that maybe it was not a good, we need more studies. But in these days, we have enough studies to prove that in the correct patient, the resin infiltration is a wonderful alternative. Some dentists here in the US, they use the term icon when they refer to the resin infiltration. I am not going to use the term icon for one reason, because icon is the brand name and there are other brand names. What happened is the first one was the icon, and that's what happened when, you know, the first Kleenex, I don't have Kleenex here in my office, but we call Kleenex, but as you know, that is, you know, papers that everybody called Kleenex because it was the first one who came to the market. So resin infiltration. Resin infiltration also can be used for white spot lesions, and it works beautiful. How often you see patients who after ortho treatment, they ended up with a bunch of white spots, and before resin infiltration, we didn't have too many options. So resin infiltration can be used for white spots, and resin infiltration can be also used for interproximal caries lesions. So resin infiltration may reduce the lesion progression and minimize secondary caries. requires no preparation, and then you don't have any restoration margin. Using the picture that you see on the right side of the screen, and I hope that you see that, resin infiltration is perfect for caries lesions, interproximal caries lesions who are not at the middle of the dentin. So resin infiltration can be used in the situations who are labeled on the picture that you see on the right side, E1, E2, D1. If you have a caries lesions who are in the situation D2 or who are already past the midpoint in between the dentin-enamic junction and the pulp, in that situation, resin infiltration is contraindicated. And obviously, D3 is also contraindicated. One of the problems of resin infiltration that I think is going to be solved soon, but this is a problem, resin infiltration is radiolucent. That means that when you, over time, if you use the technique and then you bring the patient later and you take a Bidewin, you are not going to be able to see the composite because the composite is radiolucent. The components of the resin infiltration kit are the ethanol or the Icon Dry. And again, I don't want to use Icon because that's the brand name. So the components are the ethanol, and I'm going to explain to you why we need to use it. I'm sure many of you are already using resin infiltration in Iran, so I'm sure you are an expert using this technique. So I'm sorry if you have been doing this for the last 10 years. So the components are the ethanol, the 15% hydrochloric acid. That's the component who replaces the 37% orthophosphoric acid in the composites. Then the infiltrant, which is the methacrylate-based resin matrix, is a flowable composite. So, and then the indications of the resin infiltration for non-cavitated caries lesions, as I explained before, E1 to D1. The American Academy of Pediatric Dentistry in the reference manual, we just came with a new reference manual. And by the way, I have the reference manual here, just came this year. We have a new reference manual every year. If anybody listens to this lecture, if you want to have any specific chapter of the reference manual, I have all the PDF files, so I can share with you that. So there is a chapter in the reference manual of the American Academy of Pediatric Dentistry about the use of resin infiltration. And this quote is from the chapter. From randomized controlled trials, there is evidence in favor of resin infiltration as the treatment option for small, non-cavitated E1 to D1 interproximal caries lesions in permanent teeth. I would love my dentist when I was a child to use resin infiltration because I'm sure I have a bunch of small interproximal cavities and he decided to just open it up and do occlusal distal or occlusal mesial. So based on randomized clinical trials, resin infiltration significantly improved the clinical appearance, also white spot lesions, and visually reduce the size. Why we use hydrochloric acid 15% rather than 37% orthophosphoric acid? The reason is 15% hydrochloric acid is a lot more powerful. In other words, it's going to create much better mechanical retention, which we need that. Remember, when we are using resin infiltration, we are not providing any mechanical additional adhesion of or preparation of the tooth, and this is interproximal. So the 15% hydrochloric acid that you see in this picture is going to cause more demineralization of the enamel and is going to create bigger microtubules who are going to facilitate the adhesion of the infiltrant, which is the resin. So the infiltration, which is the flowable composite, infiltrate the caries lesions, stop the lesion progression by establishing a diffusion barrier, and also improve the aesthetics when you use resin infiltration for white spots by replacing demineralized enamel with an infiltrant with a similar refractory index. Unfortunately, is radiolucent. So this is one of the kits. Forget about that. You can close your eyes, don't see icon, but this is one of the options that is available. Is one of the options that we use here. So the interproximal technique takes time to learn how to use it. I will tell you what I'm using in these days. So you're supposed to clean the tooth, then you need to separate. You need to create a small separation between the teeth. You have two options. The kit comes with a green wedge. They come with some separators that you can use, or this is what I'm doing. I prefer to use the ortho separators for about 5 to 7 days. So in my office and here at the hospital, when we have that lesion, mesial of the lower first permanent molar, it's an interproximal lesion, we place an orthodontic separator for about a week, and then we bring back the patient. So I prefer to use the ortho separator. Then we remove the separator, we place a rubber dam, or we use any other form of isolation. Then we etch with the hypochloric acid for 2 minutes, a lot longer than when we use the orthophosphoric acid. We suction, we rinse. Then we place the ethanol, which is also an alcohol. And why we place the ethanol is to dry the tooth, to dry the surface that we just placed the hydrochloric acid. Then using a device that I will show you in a minute, we place the composite, the infiltrant or the flowable composite, which is the same. For 3 minutes, we air dry, we floss a little bit, we cure for 40 seconds. And if you wanted, you can do that again. Leave the flowable composite for 1 minute, air dry, and cure again for 40 seconds. And then you can slightly polish with a strip in between the teeth. So imagine this could be a child that is coming to your office today or tomorrow. So imagine if you have that mesial lesion in the lower molar. If you have that, in the old days, we don't do that anymore here. But in the old days, you will do a MO composite or MO amalgam. That for me cannot be done anymore in dentistry. We need to stop to do that. Because once you take that tooth, that's a permanent tooth. Who is going to be with that child until when? That tooth is going to be with the child until what happened with that child? Until the child is not anymore in this world. Until we die. The tooth will be with us. So once you decide to grab the highest speed and do a MO, you are taking some healthy tissue, and then if you take that healthy tissue, you need to place a composite, and then that composite will stay forever. That's the reason that using the resin infiltration is a perfect technique to try to preserve tooth structure, and you preserve that there. So then we use the ortho separators for about a week. You can see in the bottom picture that you can see that space between the molar and the crown. And then we go with the 3 steps, and each step comes with that device. So the first step is the hydrochloric acid. Then after that, we rinse. The second step is the ethanol. We rinse. And then the third step is the infiltrant, which is the flowable composite. And then we place that and we squeeze that for about 2 or 3 minutes, just a little bit. I mean, you don't need to spend 3 minutes squeezing the syringe because otherwise it's going to be everywhere. It's depending on each case. You just squeeze a little bit, and then after that you cure, and then you can repeat that if you need it. For white spots, it's pretty much the same technique. For white spots, you go first with the 15% hydrochloric acid. Then after that, you dry with the ethanol. It's a lot easier because it's a free surface. And then after that, you go and place the infiltrant. Here in the United States, we have a code for that. What means we have a code is we can bill for that. So resin infiltration is paid by the insurance companies. And if the patient is coming to the office without any dental insurance, we can bill for that, whatever you think is appropriate for billing for that. But we have a CDT code. CDT code means that we have a dental code that the insurance companies recognize as a valid dental procedure, and we get paid for that. And so that code is there, and the services placement of an infiltrating resin restoration for straining, stabilization, or limiting the progression of a caries lesion. Beautiful. Resin infiltration is probably about 70% of the interproximal lesions that we see here in our program. We are doing resin infiltration rather than doing a DO or MO. Okay. So what we are going to do now, I'm sorry, these couple of slides are not here. This is here. Okay, I already put this, the infiltrant, this one. Okay, I'm sorry. I need to kind of skip here this because we are going to the last part. 1 second, don't leave. Don't leave. Okay, I'm coming back. I hope that you can see this. Okay. So we are going to move from resin infiltration. We are going to move into our next topic, which is one of the topics that I also love it, dentin substitutes. And I think so for us as a pediatric dentist, new frontiers are the resin infiltration and the dentin substitutes. These are the two new frontiers, resin infiltration and dentin substitutes. I don't know in Iran, which one are you using more often in terms of dentin substitutes, MTA or biodentin? These are the two materials who are under the title dentin substitutes. The email that you see here on the bottom of the slides is also the email that if you want to have this PowerPoint, you can also send me an email to this address. This PowerPoint is 350 slides. So I skip a lot of slides because otherwise I will stay here the whole day and I need to be respectful with your time. So we are going to move into dentin substitutes. Biodentin is the number one. And then we are going to talk about MTA. I don't have any financial connection with this company, and this company is not paying me any pennies or any money to give this lecture today. The same from the MTA. So biodentin is a bioactive material that promotes pulp self-healing capacity. Biodentin is perfect for indirect and direct pulp caps and pulpotomies. Biodentin can be used to promote apexicogenesis, which I don't do that. Obviously, I don't do that. And one of the big good properties of biodentin is a high pH. And why is a good advantage? Because as you know, the same that silver diamine, the high pH, which is between 10 and 12, pretty alkaline, that decreases the risk of bacterial infection. So that high pH, which is coming from the materials of the biodentin, provides a very strong antimicrobial activity. Some of the important properties of biodentin is one, the sets in about 10 to 12 minutes. That's a difference with MTA. MTA takes a long time to set. Also, there is a natural, listen this, natural micromechanical anchorage for excellent sealing properties without any surface preparation. So you can also place biodentin, you can place silver diamine, and then over the silver diamine, you can place biodentin as a liner. And you really don't need to have any previous prep of the tooth because the mechanical properties of biodentin will have an excellent margin adaptation. One of the reasons that we call biodentin as well as MTA dentin substitutes is because these two materials, biodentin and MTA, they have very similar mechanical properties as the human dentin. Difference with resin infiltration, biodentin and MTA, they are both radio-opaque. With biodentin, it's possible to complete the restoration in the same session. Also, the restoration can be completed. So if you just want to leave as a cement, the biodentin, you can complete the restoration 6 months later. And the study shows that the integrity of the biodentin is pretty good over time. Biodentin decreases the postoperative pain. And with biodentin, there is no need for extra bonding. So you can just place the biodentin over the tooth. Remember, biodentin can be also used for direct pulp cap when you are doing pulpotomies. Here in our program, we, 4 years ago, ferric sulfate was the most common dental material used for pulpotomies. In these days, 2021, the most common dental material used for pulpotomies is either biodentin or MTA. So these are the materials that we are using as a direct pulp cap. The clinical indications of Biodentin, that's the one that we are using here as a pulp cap. Biodentin can be applied directly into the pulp. It's an excellent material for dental trauma. When you have a class 3, which is the crown complicated dental trauma, you have the pulp exposed, you can place Biodentin directly. So it's an excellent material applied directly into the pulp. And one of the reasons that Biodentin is a good material is because it induces a reparative dentin formation. And you can read the reason, because there is a modulation of the pulse help TGF beta. Oops. Also, we can use Biodentin for pulpotomy. Endodontists are using Biodentin for root end filling. We also use here Biodentin as a dentin substitute. So that means that we use Biodentin as a liner in between the floor of the prep and the final restoration, which could be a composite or could be an amalgam. So we use Biodentin under composite for posterior restorations. Endodontists also use Biodentin for perforation repair, and endodontists also use Biodentin for root canal filling and apex closure. I also need to talk about MTA. So between MTA and Biodentin, that's the materials that I think are the true new frontiers. 10 years ago, probably MTA was not available, Biodentin was not available. So MTA, we also use, MTA has been in the market a little bit longer than Biodentin. MTA is mineral trioxide aggregate, which is a biocompatible cement, is not cytotoxic. The properties of MTA are very similar to the properties of Biodentin in terms of biocompatibility with the pulp, minimal leaking around the margins like Biodentin. MTA is very alkaline. That means that the pH is quite high. And if we place MTA in an acidic environment, that can prevent the MTA from setting. Clinical indications, pulp cap. We also use MTA for pulp cap here. Pulpotomy in primary and permanent teeth. And perforation repair by the endodontist, pretty similar indications that Biodentin, root end filling and root canal filling. So when you compare MTA by Biodentin, they are very similar. They work very similar. They are expensive, at least here in the United States. I don't know how much expensive they are in Iran. Here in the United States, these materials are expensive. Obviously, that's a factor that you need to account when you are doing your treatment in your office. The composition of MTA on Biodentin is similar. Biodentin comes in a capsule. It's a powder that you need to put the water, a liquid, into the capsule, and then you put that in an amalgamator. So the amalgamator is the one who mixes the Biodentin. MTA comes in a liquid, in a powder, and then you mix that. However, in these days, just recently, we have a company who produces MTA who just came with a pre-mixed MTA, which is wonderful because it's coming in a syringe, it's pre-mixed, so you can just turn the syringe a little bit, the material will come, and the material is already prepared. So you don't need to waste material. You just push out exactly the amount of MTA that you needed. So this is the chemical composition of Biodentin. The powder is basically 3-calcium silicate with other materials, is radio opaque. And this is the composition of MTA. So you can tell that if I go back, I hope that the slide is coming back. Pretty much the main difference between MTA and Biodentin is the amount of 3-calcium silicate. In Biodentin is about 80%, in MTA is 66%. Setting time is also different. MTA, the setting time is about 70 minutes, 70. The final setting time with MTA is 175 minutes. Biodentin is 6 minutes, the initial setting time, and the final setting time of Biodentin is about 10 minutes. Why is the difference in times of the setting time? Is because in Biodentin, there is a setting accelerator that results in faster setting, improving the properties and the strength. Density and porosity. If you compare side to side Biodentin and MTA, this is a critical factor because you want a material with no porosity and high density, because this is going to be related with the amount of leakage and the outcomes of the treatment. Conclusion, MTA and biodentin, they have pretty lower porosity. So they are pretty much the same. Biodentin, a little bit lower porosity. That means that the material provides a better interface with the dentin. But in clinical terms, they are basically the same. The comprehensive strength is a little bit higher with biodentin. So in conclusion, the compressive strength and the porosity a little bit better with biodentin, but I don't think so there is a huge clinical implication of that. Radiopacity, excellent for both materials. I wish we have that in resin infiltration. With resin infiltration, we don't have that. Antibacterial activity, they both are excellent. They both are pretty higher pH, what means that the bacteria, as soon as they are in contact with MTA or biodentin, they run away. Biocompatibility, I know everybody here listen to this lecture, we are pediatric dentists. When we do a pulpotomy, we want a material who is going to be in contact with the pulp with a high biocompatibility. MTA and biodentin, they have an excellent biocompatibility and no question better than glass ionomers, much better than ferric sulfate, much better than any other material that you are using as direct pulp cap when you do your pulpotomies. No question about that. And these are some of the limitations. I think so the main limitations of these materials is probably the high cost, expensive materials. Okay, I want to finish here. I have, again, almost 350 slides. I just check here. If anybody wants to have this lecture, I would love to share the PowerPoint. You can send me the email there, or the other one that I provide in the lecture. I want to, first of all, big thank you to listen to this lecture. And secondly, I would love to have more lectures in the future. Now that I have the permission to give this lecture, remember, I am a radiologist and I'm oral medicine specialist. So I have wonderful lectures about oral pathology and oral radiology in children. Topics a lot more interesting than dental materials. I promise you that I have an amazing picture. So maybe before the end of this year, we can set up one more lecture or two lectures. I would love to do it as many times as you want. And we have this permit and we can do that. So I want to thank you for the invitation and I want to thank you everybody for listening to this lecture.
Well, thank you very much, dear Dr. Yepes. I don't know, in fact, how long the permit that you have finally got will work for having further presentations, or you need to just, we have to wait for another 14 months to get another license or not.
I think so. I think so. The license is for a year. I need to check that.
So we will use it up. We will use it up in 1 year so that we can get benefit from your knowledge. And believe it or not, I'm still struggling with finding the right words to properly describe how outstanding and fantastic was your presentation. And thank you so much for delivering to us such a wonderful presentation. And I'm grateful for the time that you devoted for Tehran University of Medical Sciences in your very busy schedule. Again, for the last call, I wanted to ask my colleagues, students, postgraduate students, if they had any questions. You can just ask or write in the chat box. Dr. Yepes, a certificate of appreciation has been prepared by the University International Sector, and I will share it with you via email. And I'm speechless about your very fruitful presentation that you provided. I'm
Dr.
sure
Milani,
that
can I ask you a favor? Can you send me a PDF copy of this, because I want to send that?
I will surely do that after finishing this program. I will surely send you the PDF of this certificate. And dear colleagues, any questions? I'm just checking the chat box.
I want to send the certificate to the dean of the dental school. I want to do that because I want to tell the dean that I worked so hard to get this license to give this lecture, and I will keep doing that.
Yeah, I was getting a little bit hopeless for getting the license, and Hopefully, after just checking everything, we found that he finally got it, and it was a very good surprise for all of us. You know, it's a great honor to have you here, although it's virtually, and I hope that in very near future we can host you here in Tehran, and we will have a very good quizzing for you, and we will just like look you around. Just that will be very fun for us.
I would love to go to Iran. I will love it. I will love it because
welcomed here. Yeah,
knowledge is universal. And I would love to be there. Plus, the Tehran University reputation is the best, one of the best universities in the world. So for me, it will be something just amazing to have the opportunity to visit the university. So, so thank you so much. I'm here looking at the chat. I don't see too many questions. I will ask you a huge favor. I need to finish. I need to be in 5 minutes in the clinic. They are waiting for me. So if there's any follow-up questions, please send me to the email and I will answer there, okay?
Yeah, thank you very much. I'm speechless. I can't find any words how to describe how fantastic was your presentation, and I'm sure that all my colleagues benefited from this outstanding speech that you provided us. Thank you so much. I will send a certificate, and thanks for your attention, all my colleagues, friends, and students. Hope to see you in the near future, Dr. Yappas.
Thank you so much, and God bless you, and have a good day. Bye-bye.
You too, have a lovely day. Thank you. And this is the end of our meeting. Thank you all. Thank you, Dr. Sasha, for hosting this meeting. All my colleagues and postgraduate students. Hope to see you again very soon with other fascinating lectures. Have a lovely day and bye-bye.